Hello everyone. Welcome to the IAC webinar today. I'm pleased to say that we have Dr. Ajit Paintal here to talk about salivary gland cytology. The talk is entitled "A Morphologic Paradigm and Advances in Reporting." Dr. Paintal is currently a pathologist at the Northshore University Health System in Evanston, Illinois. He completed his residency in anatomic and clinical pathology and fellowship in cytopathology at the University of Chicago. He subsequently completed an oncologic pathology fellowship at Memorial Sloan Kettering Cancer Center, and prior to his current role, he was an assistant professor of pathology at the Northwestern University Feinberg School of Medicine, where he served as the residency program director. His interests include cytopathology, head and neck pathology, and gynecologic pathology. And I just want to welcome him, and with no further ado, I'll turn it over to him. Thank you.
All right, well, thanks for the kind introduction. As Dr. Vanden mentioned, our topic today is salivary gland cytology with focus on a pattern-based approach and advances in reporting. And I think salivary gland cytology is an important and worthy topic for discussion this morning for several reasons. First of all, it's a relatively common specimen type, but not as common as maybe certain other specimen types in cytology, things like thyroid FNAs, for example. So it's something that we'll pretty much all see on a fairly regular basis, but not in huge numbers of specimens, maybe just a couple times a week maybe. So we see it, but we don't see it all that often to develop the comfort level that we might in something like thyroid, for example. The next reason I think this is an important topic for discussion is because, again, in contrast to thyroid, this is a specimen type where you're not looking for maybe 2 or 3 different disease entities, but rather, there are dozens of separate tumors that have been described in the salivary gland, and they all have overlapping morphologies in many cases, although some of them are more distinctive than others. So there's a wide morphologic range of entities that you can see in the specimen type, another reason why this is an important topic for discussion. And finally, as I'm sure everyone is aware of, this is an area where there's been a lot of sort of motion and development in the last few years. And so, we just in the last few months have the Milan system for the reporting of salivary gland cytopathology that's been published. So we'll sort of touch on that document and on those developments sort of towards the end of this talk. So first off, I have nothing to disclose. And again, we kind of want to approach the topic of salivary gland cytology in a systematic sort of a fashion. So first we'll discuss broadly the role of FNA in the management of salivary gland lesions and just touch upon the role of pathology in the management of salivary gland lesions in general. Next we'll discuss the normal morphologic findings in a salivary gland aspirate. After that we'll spend the bulk of the talk discussing the various morphologic patterns that you can see in salivary gland cytology. So what are the big broad categories of patterns that you can see, and how do you use those patterns and other more discrete features to hone down on a definitive diagnosis if possible in these cases. Next, we'll very briefly discuss the uses of ancillary studies and immunohistochemistry, for example, in the diagnosis of these lesions if you're lucky enough to have a cell block. And finally, we'll touch upon some of the proposed changes in reporting, the Milan system that everyone I think is aware of, and also the Pittsburgh system, which hasn't gotten as much traction, but which I think is very intriguing as well. Okay, so the role of salivary gland cytology in these lesions. Whenever you get a salivary gland aspirate from a clinician, just as with any other specimen type, you can kind of think of it as, encompassing a series of questions. And so that's kind of the way to approach these in regards to reporting. So the first question you're going to kind of implicitly be addressing in a salivary gland FNA is the lesion you're looking at neoplastic? Again, in contrast to something like the thyroid, in most aspirates of salivary gland lesions, if they're sticking a needle in it, it's going to be a neoplasm, and as such, it's likely going to be resected. In some cases, you may be dealing with something that's inflammatory, something like chronic sialadenitis, for example. And so if you can, corroborate a diagnosis of chronic sialadenitis and agree with that clinical impression, that may have an impact in changing management in the sense that they may not resect the lesion. The next question doesn't come up that often, but it's something to always consider is, are you dealing with a hematopoietic lesion? Assuming you are dealing with a neoplasm, are we sure that it's epithelial or mesenchymal, or is there a chance that it's hematopoietic, something like a diffuse large B-cell lymphoma or a marginal zone lymphoma? Because if if you can identify something as being a hematopoietic lesion and characterize it based on IHC and maybe flow cytometry, then you're going to change management for this patient as well. Instead of being a surgical candidate, they may just be treated by a medical oncologist for whatever their hematopoietic neoplasm is. The next important question, although not as important as you might think, is presuming that we're dealing with an epithelial neoplasm, which is again going to be most aspirates, is this lesion malignant or not? Because that will have some bearing on the surgical approach and how the surgeon sort of goes after the lesion. But more important than the question of is a lesion malignant or not is the question of is it a high-grade malignancy on the one hand or a low-grade malignancy / benign lesion on the other hand. Because if you can identify something as being a high-grade malignancy, that is someone that's potentially going to be treated in a more aggressive fashion. For example, they may sacrifice the facial nerve, go after the deep lobe of the parotid, and assuming the patient has clinically evident disease in their neck, they may do an elective neck dissection as well. So that's an important point. Really, for most salivary gland aspirates, the important distinction is not if something is benign or malignant, but rather is it a high-grade malignancy on the one hand, which will be treated in an aggressive fashion, versus a low-grade or benign lesion on the other hand. Again, low-grade malignancies and benign lesions from a surgical standpoint are treated relatively similarly. So it's important to keep these sort of questions straight in your mind as you're addressing the specimen that the clinician is sending you. So, again, first, is it neoplastic or not? If it is, and it probably is, it'll be resected. If you can corroborate an impression of a chronic sialadenitis, that may be someone that they maybe just observe and not resect at least immediately. If you can identify something as being a hematopoietic malignancy, again, if it's something like a lymphoma, they likely not resect. They may just treat the patient with chemotherapy, assuming you have enough to reach a definitive diagnosis based on this aspirate alone. Again, if you have a cell block and flow cytometry, that is something you could potentially do. If a lesion is malignant or benign, that does have some impact, but not as much as you might think. Really, again, the most important question is, are you dealing with a high-grade malignancy on the one hand or a benign lesion / low-grade malignancy on the other hand? Because that is really the main question that the surgeon is asking when determining their surgical approach for a salivary gland neoplasm. And, even in the postoperative setting, when they're trying to determine adjuvant therapy, the grade is very important in these salivary gland tumors. So, of course, we have 40-some salivary gland tumors that have been identified and, documented in the WHO manual. But really, as far as the clinician's thinking goes, they really think of these neoplasms as just going into one of three boxes. Either they're benign neoplasms, low-grade malignancies, or high-grade malignancies. And again, if you've got a benign neoplasm, you're just going to get resected. If you've got a low-grade malignancy, you'll likely just be resected alone without any adjuvant therapy. You can see that, in this chart, assuming you have a low-grade histology, if you're dealing with low-stage disease and you have negative margins, the patient is essentially done. Things that will prompt the use of adjuvant radiation would be, if you have positive margins, if you have high-stage disease or positive nodes, or the other thing importantly is high-grade histology for dealing with the high-grade malignancy. Note that a neck dissection in the case of a salivary gland tumor is really only indicated in people with clinical disease, usually with high-grade histology. And chemotherapy essentially is saved for people with distant mets or unresectable disease. So, grading a tumor, whether it's low-grade or high-grade, is going to be important both in the preoperative setting and in the postoperative setting in determining who's going to get adjuvant therapy and potentially a neck dissection. So the grade is very important in these salivary gland tumors, and luckily for us, we don't have to worry too much about grading salivary gland tumors because most of them will actually have an implicit grade, so a grade that's implicit in the diagnosis itself. So, for example, for low-grade malignancies, low-risk malignancies, you have things like acinic cell carcinoma, epithelial-myoepithelial carcinoma, PLGA, now just called polymorphous adenocarcinoma, basal cell adenocarcinoma. And on the high-risk side, the high-grade side of things, you have things like your rare salivary gland primary squamous cell carcinoma, adenoid cystic carcinoma, large cell carcinoma, carcinoma X plemorphic adenoma, dedifferentiated adenoid cystic, acinic cell, and other tumor types. So really, the only tumors that you have to worry about grading on a regular basis, both in an aspirate as well as in a resected specimen, are Mucoepidermoid carcinomas. And we'll kind of allude a little bit more to that as we move forward. But again, the key point is that most salivary gland tumors actually have an intrinsic grade, and you don't have to worry about grading them either in an aspirate or in a resected specimen. The main tumor type that you mostly are called upon to grade, again, in both the pre-op and post-op setting to determine approach, is going to be mucoepidermoid carcinoma, because you can, again, have low, intermediate, and high-grade versions of this tumor. So, moving forward, just general principles in salivary gland cytology. Again, we kind of alluded to this earlier, but, there are dozens, 40-something different salivary gland neoplasms that have been described. And unfortunately for us, there's a lot of morphologic overlap between these dozens of different salivary gland tumors. So they look very similar to each other, many of them on aspirates alone, which introduces a lot of difficulty and a lot of consternation in regards to how to classify these tumors. The lucky thing for us is that the two most common lesions, and maybe several other lesions that occur fairly frequently, but definitely the two most common lesions, meaning Warthin's tumor and Plemorphic adenoma, are generally easy to recognize and diagnose in aspirate specimens. So even though there's a lot of morphologic overlap in salivary gland neoplasms, and it can be very difficult to diagnose many of them and distinguish them from their mimickers, really the one thing we have going for us is that the two most common lesions, again, Plemorphic adenoma and Warthin's tumor, are relatively easy to diagnose and recognize in aspirate specimens, and you can be very confident in a diagnosis of either of these two lesions. So again, lots of overlap, lots of different entities, but luckily, a large proportion of these aspirates are going to be one of those two things, Warthin's and PAs, things that we can identify and diagnose with relative ease, with just a little bit of experience. So we'll start off with just the normal findings in a salivary gland aspirate, so just normal cytology that we see in this site. So again, we have both serous as well as mucinous salivary glands. The parotid gland is going to be almost entirely serous, and so here's an aspirate from a parotid gland. You can see at low power, this very characteristic grape-like arrangement. You have these nice rounded salivary gland acini that feed into these sort of more inconspicuous ductal structures and are also tied together by blood vessels and a bit of connective tissue. But this low power bunch of grapes appearance is very characteristic, and again, it kind of arborizes and is held together by ductal structures as well as blood vessels. You can see at higher power, again, this is a serous gland, so the acinar cells will actually have a large quantity of this very azurophilic granular cytoplasm, so very coarsely granular blue azurophilic cytoplasm. The nuclei are somewhat eccentric. You can see that the cell membranes are very inconspicuous, so this has a very sort of syncytial growth pattern within these acini, you can say. So whenever you see these nice balls, these little spheres of acinar cells, that's going to be your clue, even in a very scanty aspirate. If you're lucky enough to have these larger fragments, again, you can see this arborizing growth pattern, and you can see the arrangement of the acini around the striated and the intercalated ducts, as well as some blood vessels as well. So this sort of recapitulates what we see in histology. Again, this is more of a seromucinous gland we're dealing with now. So again, you have the nice round serous acini as well as some mucinous cells, some more clearer flocculent mucinous cells. The serous acini contain, again, abundant granular, sort of basophilic cytoplasm, very coarsely granular, nuclei are eccentric, and the acini will feed into these inconspicuous striated ducts, which will then feed into the larger intercalated ducts. So again, the cytology kind of recapitulates what we see in histology as well. And so, just as with any specimen type in the realm of pathology, I think one useful thing to do is to keep in mind just the overall big, broad categorization of the different lesions. And in the case of these salivary gland FNAs, just keep in mind the big, broad morphologic categories that you may encounter. So a good approach for these lesions, just because there are so many separate neoplasms that have been described, is to first, when you're dealing with an aspirate and you identify it as being a lesion, is to identify the big, broad overall morphologic pattern, and then look for specific features to hone down, if possible, on a definitive diagnosis, or a diagnosis that's as definitive as you're comfortable being given the specimen and the entity. So the 5 categories that I think it's useful to separate these aspirates into would be the epithelial and stromal sort of pattern, and this is comprised of tumors that have an epithelioid or basaloid sort of component, as well as a bit of stromal material, maybe 20-25% or more stromal material. Next, we have the basaloid category, which is comprised of cells with bland nuclei and high NC ratios that may have a bit of stromal material, but not rising to the amount that you see in the epithelial-stromal pattern. So basaloid, again, bland cells, high NC ratios, not a lot of stromal material. The next pattern is going to be the granular pattern. This is comprised of, again, relatively bland, low-grade looking cells with abundant granular cytoplasm. This category includes oncocytic type tumors as well as acinic cell carcinomas, as well as a few other oddities. The next category would be your squamoid category. This is going to be comprised of tumors that have more dense and angulated cytoplasm. So they resemble squamous cells, or at the very least, squamoid cells, similar to what you might see in metaplastic cells in the Pap test. Again, more dense and more angulated cytoplasm. And the final category you're going to encounter is going to be the plemorphic category, in my mind, and that's just going to be comprised of tumors with very high-grade nuclei, tumors that are sort of overtly malignant, and the main question is, how are you going to classify them? But, based on the nuclear atypia and other features, these are going to be tumors that you'll easily identify as being malignant. And it's important to place tumors and aspirates into one of these 5 categories because really your approach to diagnosis is going to differ greatly depending on which category you're initially placing your aspirate into. So I think this is where we're going to spend the bulk of our time with this talk, to just go through these categories and to go through the approach in as much depth as we can. And describe these categories and go over which are the features that we use to reach a definitive diagnosis when facing an aspirate with one of these patterns. Okay, so the epithelial-stromal pattern is what we'll start out with. And the epithelial and stromal pattern is defined as being an aspirate that's comprised of epithelioid or basaloid cells. So, epithelial cells or myoepithelial cells that may have some cytoplasm or may have very little cytoplasm. But the key thing is you've got some stromal material, extracellular stromal material, and it comprises at least 25% of sort of the volume of material in the aspirate. So we've got epithelioid or basaloid cells, and you've got at least 25% of the volume of the aspirate being comprised of stroma. So when you're dealing with the epithelial-stromal pattern, really the 2 entities that you're going to mostly have in your differential are going to be plemorphic adenoma and adenoid cystic carcinoma. An important distinction in that plemorphic adenoma is obviously benign, and adenoid cystic is a high-grade malignancy that will trigger a very aggressive surgical approach. So to distinguish these 2 neoplasms that fall within the epithelial-stromal pattern, the key things you're going to want to assess: the morphology of the epithelial component, the relationship of the cells, the lesional cells to the stromal material, and also the character of the stroma. Those 3 things are important to make this distinction between a PA and adenoid cystic. The morphology of the epithelial component, relationship of cells to the stroma, and also the character and the texture of the stroma. So here's your typical plemorphic adenoma. I'm sure everyone is familiar with. And again, you kind of have a triphasic look to your classic plemorphic adenoma. You have epithelial cells, myoepithelial cells, and you have stromal material. So starting with the cellular components, it can sometimes be difficult to tell epithelial from myoepithelial cells. For my money, if you see cohesive cells forming a cluster, a group of cells that's, all the cells are touching each other, for my money, those are epithelial cells. And the epithelial component in a plemorphic adenoma can have a number of different looks. It can be, squamous, it can be mucinous, but usually what you see is this very just nondescript glandular sort of look to the cells. But again, the fact that they're making a cohesive group and all the cells are touching, to me this is indicative of epithelial differentiation. The myoepithelial cells are a bit different. You typically don't see these in cohesive groups. The myoepithelial cells will be more individual and dispersed. They'll either be floating freely in the background of the aspirate, or else they'll be entrapped within the stromal material. And myoepithelial cells, just like the epithelial cells, can have a number of different looks to them. They're usually spindled, but they can be plasmacytoid, they can be epithelioid, or they can be clear. The plasmacytoid myoepithelial cell, so-called hyaline cell, is supposed to be somewhat specific for plemorphic adenoma. But again, the myoepithelial cells are more individually spaced, either within the stroma or just floating around in the background. So we have both epithelial as well as myoepithelial cells, and these two cell types are distinct from one another. That's an important feature. Again, a key feature with the myoepithelial cells is that you typically see them individually placed within the stromal material, kind of percolating through the stroma, not forming groups, but just individually sort of, again, working their way. That's a key feature of myoepithelial cells in a plemorphic adenoma. Again, they can be spindled, epithelioid, or plasmacytoid. Again, if you look in the pap stain, and the metachromatic stroma kind of drops out to some degree, although you can still appreciate the fibrillary nature here. So, again, the three main components of a PA, epithelium, myoepithelium, as well as stroma. And the stroma should be fibrillary, not homogeneous and hyaline, but rather fibrillary, kind of akin to, I guess, what we call in the States the troll doll hair, if you remember those toys from 15, 20 years ago, but very fibrillary, and you can appreciate the fibrillary nature in the pap. Again, you can't see the metachromatic color, but you still see the fibrillary nature of the stromal material here. And so, these features are in stark contrast to what you see in an adenoid cystic carcinoma. Again, you want to look at the cells, the relationship of the cells to the stroma, and also the character of the stroma. So in a plemorphic adenoma, we had two different cell types. We had very fibrillary stroma, and we had the myoepithelial cells percolating to the stroma. And keep those things in mind as we discuss adenoid cystic carcinoma. In adenoid cystic carcinoma, really we're dealing with a much more monotonous population of cells, and these cells are basaloid. Basaloid meaning that even though this is a high-grade tumor, the tumor cells are very bland and monotonous. So if you look at the cell-per-cell level, this does not look like a malignant tumor necessarily. Again, it's very bland, monotonous cells with high NC ratios, but a very uniform cell population, and it's entirely comprised of these basaloid cells. As far as the relationship of the cells to the stroma, you can appreciate that in an adenoid cystic, you typically have the cells and the stroma sharply sort of demarcated from each other. You can see a sharp line and distinction between the stroma and the basaloid cells. We don't have the cells percolating through the stroma as we did in a plemorphic adenoma. And again, the final important thing to pay attention to is the stromal material. Classically, in adenoid cystic, you get these nice homogeneous balls of stromal material. We don't have that fibrillary quality. The stromal material is very sharply defined, and it does not have any internal structure. So again, these hyaline globules, gumdrops as DeMay calls them, just very sharply defined balls of stromal material. You can see these in other tumor types besides adenoid cystic carcinoma. For my money, the larger these stromal balls are, the more believable it is to me. So the more there are, the larger they are, the more believable it is. And also, again, you want to look at the morphology of the cellular component. You should have all basaloid cells in the background as well. So again, the differences in cytology are recapitulated in histology as well. So in a PA, you have multiple different cell types. You have the cells percolating through the stroma, and you have this very wispy chondromyxoidy sort of stroma. In an adenoid cystic carcinoma, you have a much more homogeneous population of basaloid, high NC ratio, bland cells. You have the cells and the stromal material sharply demarcated, and the stromal material is more uniform and sort of hyaline, not as wispy and fibrillary as in a plemorphic adenoma. Again, you can appreciate that the larger the balls of stromal material and the more abundant they are, again, the more consistent with a adenoid cystic carcinoma that is to me in my mind. And again, even though these are malignant tumors, the basaloid constituent cells are very bland and monotonous with high NC ratios. So it's not the individual cells that tells you this is malignant, it's really the overall pattern and taking everything into account. Also in an adenoid cystic, in addition to the nice round spheres of stromal material, we may also have these more irregular fragments of stroma as well. So they're not round like the gumballs in adenoid cystic, but you can appreciate that this is still worrisome in that this is an irregular fragment of stroma, but again, the cells are sharply demarcated from it, and it's not fibrillary. It's very homogeneous and hyaline. So these fragments of hyaline stroma, even though they're not as specific as the gumballs for adenoid cystic carcinoma, in the right context, these are still worrisome and should get your attention and get you thinking about something like an adenoid cystic carcinoma. Again, these more irregular stromal fragments are another sort of clue in addition to those gumballs that we talked about a few minutes ago. And again, key thing, the individual cells in an adenoid cystic carcinoma are not overtly malignant or pleomorphic or anything like that. They're very bland and very monotonous. The key to this diagnosis is recognizing the overall pattern, because if you looked at the individual cells in a vacuum, there's no way you could really identify this as being a high-grade malignancy that necessitates a very aggressive surgical approach. So the overall picture is what's important. So again, for the epithelial-stromal sort of category, assuming you're dealing with an aspirate with epithelioid and basaloid cells and at least 25% stroma, your main two differential diagnoses are going to be adenoid cystic and PA. And again, the key things you're going to want to look for: the type of cells, is it one cell type versus a mixture of cell types, the relationship of the cells to the stroma, is it percolating through the stroma individually like in a plemorphic adenoma, or are the cells and stroma sharply demarcated like in an adenoid cystic? And also the character of the stroma. Is it wispy and fibrillary like a PA, or is it more sharply defined, forming spheres without internal structure like an adenoid cystic carcinoma? There are some pitfalls here. If you're dealing with a stroma-rich PA, you won't have much epithelium. And if you're dealing with a cellular PA, you won't have much stroma, conversely. Versus in an adenoid cystic, again, a lot of times they'll fit this classic characteristic appearance, but if you're dealing with something like a solid adenoid cystic, for example, those may not have very much stroma at all for you to sort of address. So that's the epithelial-stromal category. The next category is a bit trickier. That's the basaloid category. And again, similar to what we saw in an adenoid cystic, these are comprised of cells that are bland as far as their nuclei go and have high-and-C ratios. They're usually very uniform tumors with very bland nuclei, and the nuclei have high-and-C ratios, not overtly malignant in any case. There can be a bit of a stromal component in the basaloid pattern, but it's usually much less than in our epithelial-stromal pattern, maybe only on the order of less than 25%, and usually a lot less than 25%. So we don't have a lot of stromal material. We just have uniform, bland cells with high-and-C ratios. And again, this is the trickiest pattern for us to deal with, in my experience. And key points, things you're going to want to address, are going to be the cellularity, the character of the stroma, if there is any at all, and just recognize that within this category there's lots and lots of morphologic overlap. So a lot of the time you're not going to be able to reach a definitive diagnosis. So here's just, I think the best way to approach this category is just to walk you through a few cases to just highlight the overlap and highlight some of the pitfalls. So here we have a tumor. It's, I can just tell you at low power the aspirate was pretty cellular. At higher power we can see that the tumor has these clusters of cells. The cells have relatively high NC ratios, not a lot of pleomorphism, and very bland cells with high NC ratios. So just clusters of basaloid cells for the most part. You can see here that maybe there's a little bit of this hyaline stroma, but it's not making balls or anything like that, and there's not very much of it. So just a bit of this hyaline stroma, and then beyond that, you basically just have these clusters of basaloid cells. So it definitely looks to be cellular and to be a neoplasm, but beyond that, hard to say much aside from the fact that we have a bit of this stromal material here. Higher power, again, we can appreciate that these basaloid cells in the pap have very bland nuclei, very nondescript sort of granular chromatin, and not a lot of pleomorphism to these cells. So we just signed this out as a basaloid neoplasm. Again, you can take note of the hyaline stroma for whatever it's worth. And at resection, this ended up being a solid adenoid cystic carcinoma. And if you take a step back, the cells actually look very similar to the adenoid cystic we saw in the last section. It's really just that we don't have that very characteristic stromal material, except for just that bit that we saw here. So one key point, or a couple of key points, are illustrated here. First of all, in this pattern, it's very difficult. It can be very difficult to reach a definitive diagnosis. And secondly, if you do have stromal material, hyaline stromal material, that should get your attention because that's associated tends to be more associated with malignancies versus benign neoplasms. So recognizing hyaline stroma is important, and just recognizing that this category is hard to reach a definitive diagnosis with most of the time. But in this case, this is a solid adenoid cystic carcinoma. In other areas, you can maybe expect to see areas that are more typical with a more infiltrative growth pattern and a more cribriform and tubular sort of architecture to it. But again, not all adenoid cystics are going to have this classic growth pattern that's going to give you stromal balls in an aspirate. Sometimes you'll just get solid adenoid cystics, and in those cases, there's not really much stromal material to be had in the case of an aspirate. Here's another FNA, salivary gland lesion. You can see again, we have very cellular aspirate. We have these clusters of basaloid cells with bland nuclei and high INC ratios. And again, we have a little bit of this interposed hyaline stromal material that is sharply demarcated from the basaloid cells. So for my money, this looks very similar, if not identical, to what we saw in our last aspirate, which ended up being an adenoid cystic carcinoma, again, a high-grade malignancy. In this case, on resection, this ended up being an epithelial-myoepithelial carcinoma. You can appreciate these ductal structures surrounded by these sheaths of sort of clear myoepithelial cells sitting in this what tends to be more hyaline stroma, and these tumors usually have a more multinodular growth pattern. And even though this is still a carcinoma, it's a lot different beast than an adenoid cystic carcinoma. Epithelial-myoepithelial carcinoma is a low-grade malignancy, and so it's going to be approached surgically very differently than an adenoid cystic carcinoma. So our first aspirate, adenoid cystic high-grade malignancy, this aspirate looks, to my mind, almost identical. This ended up being a low-grade malignancy. It's a big difference. Here's our next aspirate. We have, again, population of uniform basaloid cells, a little bit of this interposed hyaline stroma. In this case, we were lucky enough to, in the background, find a little bit of this orangophilic keratin debris, along with this sort of cystic degeneration. So we were lucky enough to find this area of sort of more, again, cystic degeneration and keratinization, and so we were able to suggest a diagnosis of a basaloid squamous cell carcinoma. But if you didn't have that keratin debris and you didn't have that sort of necroinflammatory background, you would probably have an aspirate that just looked like this, and again, would be very similar, if not identical, to what we saw in our previous two aspirates. So again, these aspirates all looked very similar for my money. One was a high-grade malignancy, one was a low-grade malignancy, and now we're adding, a metastatic malignancy to that list. And again, these all overlap morphologically. And here's our final case. This aspirate is a lot more hypocellular. We have a lot of inflammatory cells in the background, maybe more than what you'd expect in just, the background blood. So again, we have some crushed lymphoid cells in the background. We have, again, these clusters of sort of bland basaloid cells, although they're kind of few and far in between, not a very cellular aspirate. Got some lymphoid tangles, and we have these sort of fragments of more irregular sort of stromal material. Again, not the most cellular aspirate in the world. We've got some lymphoid cells and tangles in the background, as well as these lymphoid tangles in association with these little flakes and clusters of basaloid cells. In the PAP, again, you can appreciate high INC ratios and the relatively bland nuclei in these clusters of basaloid cells. And so on resection, this ended up being a chronic sialadenitis. You can see loss of the acinar cell component, just these lymphoid follicles and a lymphoid infiltrate in association with just these residual striated and intercalated ducts. So, for my money, when I'm dealing with an aspirate in sort of this basaloid pattern, again, the key things for me are that, A, there's so much overlap between entities in this category. A lot of times, short of being able to do molecular studies on a cell block, really the most you'll be able to do is to say that you're dealing with a basaloid neoplasm and give a diagnosis. So again, we have all these advances in reporting with Milan and whatnot, but I think in dealing with these aspirates of basaloid lesions, which is always sort of the trickiest part of salivary gland cytology, I think we're still just, in most cases, just able to issue a diagnosis of basaloid neoplasm and put the ball back in the clinician's court. These are cases that are usually good to do a frozen section on at the time of surgery. But it's hard to go out on a limb too much with these aspirates. Really, the main thing I try to do is just make sure I'm not overcalling a chronic sialadenitis. So if you have a very scanty aspirate, if the radiology is kind of not definitive for a mass, and if you have lymphoid cells in the background, then you always have to have chronic sialadenitis cross your mind, because that's one diagnosis that you can suggest that may change the management. Otherwise, I think you just kind of have to punt in these cases. So for these basaloid neoplasms, there's a lot of morphologic overlap. Again, you saw the adenoid, cystic, epithelial-myoepithelial carcinoma, and basaloid squamous cell carcinoma all overlapped, and one's a MET, one's a low-grade malignancy, and one's a high-grade malignancy. And if I were to throw an aspirate of a basal cell adenoma in this PowerPoint, it would look basically identical to those other three entities. So a lot of times we just sign it out as a basal cell neoplasm, basaloid neoplasm, and give a differential diagnosis. The main thing, again, that I try to do is try to not overcall chronic sialadenitis. So these are always frustrating and not that gratifying to sign out, but this is just kind of where we are most of the time. The next pattern we'll deal with is the granular pattern. And the granular pattern is going to be comprised of aspirates that have uniform cells, typically with abundant, as you might imagine, granular cytoplasm. Again, this is mostly going to be things like acinic cell carcinoma as well as tumors comprised of oncocytes. Key things that you're going to want to assess: the consistency of the granularity, the arrangement of the cells, are they making sheets or are they making clusters, and also what is the background of the smear. So the consistency of the granularity is important, the arrangement of the cells or architecture is important, and the smear background is important. So here's just an example of a very classic Warthin's tumor. I think everyone is familiar with this. Warthin's tumor, of course, has three components to it in cytology as well as in surgical pathology. Most importantly, what you want to see is going to be just flat sheets of evenly spaced out cells with abundant granular cytoplasm. The granularity is usually brought out best in the Pap test, or in the Pap smear, or the Pap stain rather. But in general, you want to see almost exclusively just flat sheets of evenly spaced out uniform cells, again with granular cytoplasm and inconspicuous nuclei. So that's key, the flat sheets of oncocytes. The other two features that you'll see to varying proportions are going to be lymphoid cells, either in the background or sort of percolating through these sheets of epithelial cells. So lymphoid cells either in the background or in association with the epithelial cells. And finally, you want to see grungy, granular, cystic debris in the background. So that grungy cystic background, the lymphoid cells, and the epithelial component. Those are the keys for a Warthin tumor. Again, you can see in this slide lymphoid tangles, loose individual lymphocytes, as well as this very granular smear background. Those are the key things for a Warthin's tumor. But again, the most important thing for me is that the aspirate, the epithelial component of the aspirate, should entirely be comprised of flat sheets. These Warthin's tumors essentially always look the same for my money. You just get these three components to varying degrees. But the epithelial component is the most important. And again, flat sheets, relatively evenly spaced out, and this abundant granular cytoplasm, as well as bland nuclei and nucleoli. And again, these groups are punctuated by little lymphocytes as well. Here it is in the Pap, and again, the Pap brings out both the nucleoli in these oncocytes as well as the granular nature of the cytoplasm. And you can appreciate that in oncocytes, the granularity tends to be very tightly packed as well as very fine. So it's much harder to appreciate the granularity in the diff-quick, much easier in the Pap because the granularity is so tightly packed and so fine. So again, the key thing for the Warthin's is this tripartite sort of composition, but the most important thing is flat sheets of oncocytes that have very densely packed, finely granular cytoplasm. And again, it should be all sheets, almost all sheets. Here's a case to look at in contrast to the Warthin's tumor to kind of illustrate a point. We can see at low power we have a bunch of these larger groups within the aspirate. We can see that the cells comprising this aspirate, we have a few lymphocytes percolating through, but we mostly have, again, these epithelial cells, which look similar to the epithelial cells that we saw in our last Warthin's tumor. You can get a hint of dense granular cytoplasm. Again, we've got nucleoli just like a Warthin's tumor, but it's not forming the nice flat sheets. These groups are more haphazard, more overlapping. In places we even get these three-dimensional chunks. But the key thing is that you can appreciate that on a cell-per-cell basis, these cells are oncocytes, just like the oncocytes that we saw in our Warthin's tumor. Again, Nuclei are bland for the most part. They've got little nucleoli, and they have this densely packed, very finely granular cytoplasm that you can appreciate here. Again, very similar cells as the Warthin's tumor, but completely different arrangement. The groups are much more three-dimensional. You don't see the flat sheets, much more three-dimensionality to these groups. So again, once you see the three-dimensionality, three-dimensional growth, for my money, you're taking Warthin's off the table for the most part. So if it's, you still have a population of oncocytes, but you're getting more three-dimensionality and more complexity to the groups, it's not a Warthin's. It's going to be some sort of an oncocytic neoplasm. In this case, this ended up being an oncocytoma on a resection. There are oncocytic carcinomas that have been described, but usually if the cytology is bland, it's just going to be an oncocytoma. So again, in contrast to a Warthin's tumor, you won't necessarily get the granular debris in the background or the lymphoid component, but the most important thing is recognizing that three-dimensional architecture of the oncocytes and recognizing that that's not compatible with a Warthin's tumor. Final entity that we'll briefly discuss in the granular category is going to be an acinic cell carcinoma. Acinic cell carcinoma is comprised of granular cells just like a Warthin's, just like an oncocytoma, but the pattern of the aspirate is completely different. Typically in an acinic cell carcinoma, either in the pancreas or in the salivary gland, what you'll usually see in an aspirate is going to be three-dimensional heaps of tumor cells forming clumps and irregular groups, and in the background you'll see numerous stripped naked nuclei. So that combination of three-dimensional heaps of cells as well as individual bare nuclei in the background is very suggestive of an acinic cell carcinoma. Again, three-dimensional clumps of cells as well as naked nuclei. That's going to be your clue at low power. At higher power, you can appreciate that in contrast to an oncocytic tumor or a Warthin's tumor, there's going to be more nuclear atypia. Again, you still get nucleoli, but the nuclei are bigger, the nucleoli are bigger, and the nuclei tend to be a bit coarser, so more nuclear atypia than those oncocytic tumors. Also, the cytoplasm tends to be granular, but tends to be more coarsely granular. You can appreciate the granularity better in the diff-quick than you can with those oncocytic tumors. And finally, you usually have a combination of both granular and vacuolated cytoplasm. So we have nucleoli, we have atypia, we have coarsely granular as well as vacuolated cytoplasm. In many ways, this tumor, to my mind, overlaps a lot with just conventional renal cell carcinoma, but more atypia than the other tumors we talked about, more coarse granularity than the tumors we talked about, and also the vacuolation is important. Another feature you'll note here is that the cell borders tend to be less distinct than an oncocytic tumor. You tend to get more of a syncytial growth pattern. So the low power, those three-dimensional clumps and naked nuclei is different, and the high power is different as well. Again, the granularity, the atypia, and the vacuoles. Again, you can appreciate here the syncytial sort of cytoplasm, the naked nuclei, the combination of granular and vacuolated cytoplasm. Again, a striking resemblance in my mind to renal cell carcinoma. And again, you can appreciate the degree of nuclear atypia is much greater than in those other tumors. And again, on resection, you can appreciate this is a nice acinic cell carcinoma. You can see, again, this abundant, coarsely granular basophilic cytoplasm. Another tumor that may fall under this heading, something that I think has not been described all that well in cytology, is memory analog secretory carcinoma. These are tumors that in the past had been called hypogranular acinic cells. So again, they look like acinic cells, but just without that coarse basophilic granularity. These have been recognized to have a characteristic ETV6 and track rearrangement, similar to secretory carcinoma of the breast and various pediatric fibrosarcomas as well as kidney tumors. But really, if you mistake an adenoid, or rather an acinic cell carcinoma for a mammary analog secretory carcinoma, you're not going to really cause too much harm, and that they're both going to be managed the same way, and they're both low-grade malignancies. But just recognize that this is an entity people have described in the last few years, and it may overlap significantly with acinic cell carcinoma in cytology. So if you see something that looks like an acinic cell, either in SearchPath or in Cyto, without coarse basophilic granularity, this may be an entity to consider. So for the granular pattern, again, your main entities you're going to consider will be a Warthin tumor, oncocytoma, as well as acinic cell carcinoma. Warthin tumor and oncocytoma are both comprised of oncocytes, so the cells tend to be bland, tend to have fine uniform granularity with visible cell borders, again, and small nucleoli. In a Warthin's tumor, the oncocytes will be forming flat sheets, and you'll also have cyst contents and lymphocytes admixed, so those three components, versus in an oncocytoma, you may or may not have the cyst contents and lymphocytes, probably not, but what you will note is that instead of getting flat sheets, the epithelial cells will form three-dimensional clusters. That's going to be your clue. Acinic cell carcinoma looks considerably different from those other two. Again, the low power pattern is going to be three-dimensional clusters, sort of heaps of cells, as well as lots of bare naked nuclei floating around in the background. There tends to be more nuclear atypia. The granularity tends to be coarser with lots of vacuoles, and you also get inconspicuous cell borders in contrast to those oncocytic tumors. Next pattern we'll discuss is the squamoid pattern. And tumors in the squamoid pattern are comprised of cells that, again, have dense angulated cytoplasm. They look either like squamous cells or else like squamous metaplastic cells that you might see in the pap. And also note that squamous metaplasia can be seen in some salivary gland tumors. Plemorphic adenoma is the one that mostly comes to mind, as does, if you get an infarcted Warthin's tumor, that may give you squamous metaplasia as well. But aside from those entities, we typically have a very narrow diagnosis dealing with tumors in the squamoid pattern. And so key things you're going to want to address when you see an aspirate with squamoid cells, again, dense angulated cytoplasm, and that would be you want to look at the background of the smear. Do you have mucinous material? Do you have necroinflammatory debris? And also look for goblet cells. Really, in the squamoid pattern, your two main entities that you're trying to diagnose are going to be Mucoepidermoid Carcinoma and squamous cell carcinoma, usually metastatic squamous cell carcinoma. So here's a good example of a mucoepidermoid carcinoma. Again, the key thing that catches your attention is just this mucinous material in the background. It's kind of magenta, even mucinous material in the background. Very different, again, magenta, even mucinous material, very different than the granular debris we saw in the background of the Warthin's tumor. So they look different and they have completely different sort of connotations to them. So whenever you see this mucinous material in the background of a salivary gland aspirate, the first, second, and third thing to cross your mind should be a mucoepidermoid carcinoma. Especially a low-grade mucoepidermoid carcinoma, which is predominantly cystic, you may get lots of mucin but very few epithelial cells. So whenever you see this mucinous background, it should always get your attention and get you thinking of a mucoepidermoid carcinoma because, again, the lesional cells may not be very abundant in an aspirate, especially of a low-grade tumor. So again, mucoepidermoid carcinoma, the epithelial component, the cells will actually be very nondescript. A lot of times they can actually look a bit oncocytic as well, but usually what you get is this more abundant, again, angulated cytoplasm, very vaguely squamoid, like what you see in, again, metaplastic cells in the pap. And there can be a bit of granularity, again. These do overlap a bit with the granular pattern. So vaguely granular, vaguely squamoid, mucinous background, relatively bland cells, those will be your clues for more of a low-grade mucoepidermoid carcinoma. So once you see the mucin and you see these sort of nondescript squamoid cells, obviously you want to start looking for goblet cells as well. Again, the pap you can appreciate relatively bland nuclei as well as this angulated, relatively dense cytoplasm, and the cells are forming these groups. Again, you typically have two cell types in a mucoepidermoid carcinoma. We can always talk about the third cell type, intermediate cells, but you don't really, I think those are more theoretical and something you actually see in either SurgPath or cytopathology. We have our dense angulated squamoid cells, and we have our histiocyte-like cells, which are the mucin-producing cells and the diagnostic cells of these mucoepidermoid carcinomas. So the key to the diagnosis is recognizing the mucinous background, identifying the nondescript squamoid cells, and then finding a population of the mucin-producing histiocyte-like cells, the goblet cells. Sometimes they'll be abundant, as in this example, but a lot of times what you'll see is just you'll have a cluster of, again, the epidermoid squamoid cells with dense angulated cytoplasm, and punctuating these groups, you'll just have the goblet cells, the histiocyte-like cells, which are usually easier to recognize in the pap. The mucin will be highlighted pink. And so it can be hard to tell these from mucophages. So for me, what I like to do is look for cells sort of interposed into the groups of squamoid cells. So when I see the histiocyte-like cells, the goblet cells, kind of punctuating the groups of intermediate, or rather squamoid cells, that to me is the most convincing thing. So when you see it like this, where the goblet cells are not floating around in the background, where it's difficult to tell them from histiocytes, but where you see them associated with the groups of epidermoid cells, squamoid cells, that to me is the most convincing. Again, you've got your nondescript squamoid cells, and then you've got punctuation by goblet cells containing mucin. In a resection, this ended up being, again, a low-grade mucoepidermoid carcinoma. One question the surgeons may pose in an aspirate when you diagnose or suggest a mucoepidermoid carcinoma is whether you think it's a high-grade or a low-grade tumor. Grading of these is not really standardized or necessarily all that reproducible, even in resected specimens. There is a lot of overlap, I think, depending on which system you use between the low-grade and intermediate-grade and high-grade forms. But in general, in an aspirate, if you see necrosis and if you see, just overt pleomorphism and atypia, those would be things that would suggest a high-grade mucoep. But the vast majority of these should actually be lower intermediate-grade tumors. So again, if you see necrosis, you see wild atypia, those would be things that would make you suggest a high-grade tumor. Otherwise, again, the majority of these are low-grade mucoeps. And that's in contrast to this other squamoid tumor. Again, we have, in this case, interestingly, kind of a tigroid background. The groups are very angulated and jagged. We see lots of, cells with this robin egg blue cytoplasm in the background. Again, this robin's egg blue cytoplasm with these anucleate forms, these dense angulated cells, squamoid cells. But, these robin's egg blue forms suggest frank keratinization, which you essentially never see in a mucoepidermoid carcinoma. Again, it's highlighted better in the PAP. We can see that we have these sort of clusters, jagged, irregular clusters of non-keratinizing squamous cells, as well as these frankly keratinizing cells in the background. So this ended up being obviously a metastatic or a squamous cell carcinoma. So clues here would be, we don't have the mucinous background. Very importantly, we have lots of frank keratinization, which is essentially incompatible most of the time with mucoepidermoid carcinoma. And it looks just like a squamous cell carcinoma that you might see in the lung or head and neck or elsewhere. Important to note, most squamous cell carcinomas that you see in the salivary gland are going to be metastatic lesions, usually from a cutaneous primary somewhere else in the head and neck. The rare time you will see a primary squame in the salivary gland, it's usually a manifestation of carcinoma X plemorphic adenoma. Very rare to get primary de novo squamous cell carcinoma in the salivary glands. So if you see frank keratinization, see the necroinflammatory background, think more of a squame as opposed to a mucoep in this squamoid pattern. So again, key points, look for background material, squamous debris versus mucin, and also again, look for goblet cells, preferably in association with those squamoid cells in the case of a mucoep. The last pattern we'll discuss is just the pleomorphic pattern. Plemorphic pattern is just going to be when you see sheets of cells with wild atypia, and based on the degree of pleomorphism and atypia, it's usually easy in these cases to arrive at a diagnosis of a high-grade malignancy. In this pattern, really the main thing is to distinguish the different entities within different forms of high-grade malignancy. And the differential can be something like a high-grade mucoep, salivary gland ductal carcinoma, carcinoma X plemorphic adenoma, a dedifferentiated lower-grade salivary gland tumor, or a metastatic lesion. Really, if you can just identify a tumor as a high-grade malignancy, that's all you have to do most of the time. If they're worried about a metastatic lesion, if you've got a cell block, it's easy enough to rule things in or out based on IHC if you're talking about a metastatic lesion. But between the rest of the entities, these high-grade salivary gland tumors, there's a lot of overlap, and it's hard to distinguish them based on morphology alone. So IHC can be useful if you have a cell block in this category of lesions in particular to hone in on a definitive diagnosis, but really the most important thing is just exclude a metastatic lesion. And you can do that based on the clinical findings and as well as on IHC in some cases. But these are tumors, or these are aspirates where you shouldn't have a hard time telling that you're dealing not just with a malignancy, but with a high-grade malignancy. So here's an example here. We have a relatively cellular aspirate. This is a PAP. You can see at higher power these irregular clusters of cells. Again, quite a bit of variation in nuclear size and shape. even at this power. And again, you can see that the nuclei are multiple times the size of a red cell. There's some multinucleation here. There's quite a bit of pleomorphism. There's some irregular contours to the nuclear membranes, maybe a bit of pycnosis here. So a tumor that, ideally or hopefully you can recognize as a high-grade malignancy. And at this point, are we dealing with a primary or a met? Again, looking at the clinical information can help you with that. And as far as what type of tumor we're dealing with, this is a case where a cell block can help you. So here we have cluster of these cells. Again, it's a high-grade malignancy, lots of sort of karyorrhexis and pycnosis, as well as this pleomorphism and atypia. And you can appreciate the cells have this abundant eosinophilic cytoplasm. In this case, the tumor cells were positive for androgen receptor, which led us to a diagnosis in the context of a salivary gland tumor of salivary gland ductal carcinoma. But again, really the main thing would be to recognize that this is a high-grade malignancy and it's not a metastatic lesion. And again, this could easily have been something like a high-grade mucoep, carcinoma X pleomorphic adenoma, or a dedifferentiated salivary gland tumor. So these pleomorphic tumors are difficult to distinguish morphologically in small biopsies. IHC may be of value. So androgen receptor in this context is basically, defining of a salivary gland ductal carcinoma. P63 positivity might suggest a metastatic squam or a mucoepidermoid carcinoma. There are other stains like HMGA2 and plague that would suggest a carcinoma X pleomorphic adenoma, but honing down on a specific diagnosis isn't necessarily that important in an aspirate, as long as you can just exclude a metastatic lesion. So, again, a lot of these categories, in particular the basaloid category, are a bit frustrating because a lot of times you can't make a definitive diagnosis based on morphology alone, and even with IHC. There is quite a bit of literature out now about the use of ancillary studies, kind of a new generation of IHC markers that may help us with some of these lesions. So beyond just P63 and c-KIT and calponin, a lot of these markers that have been described now are related to the products of these defining translocations for these tumors. So for adenoid cystic carcinoma, for example, we've always talked about c-KIT. c-KIT is kind of dicey in the context of a resected specimen, and in the context of a small biopsy, it's not really reliable at all. I mean, it's relatively sensitive, but it can be patchy, and lots of other tumors besides adenoid cystic can have c-KIT positivity as well. So typically don't like to use it all that often. There is some work that's come out lately in regards to using IHC targeted against the MYB protein to help diagnose adenoid cystic carcinoma. MYB, NFIB is supposed to be a defining rearrangement that's present in most adenoid cystic carcinomas, and depending on whose work you read, this has been found to be a very sensitive marker, as well as almost 100% specific versus pleomorphic adenoma, the main morphologic mimic, to help you reach a diagnosis of adenoid cystic carcinoma. So again, not many people have it, but it's just something maybe useful to be aware of. Pleomorphic adenoma, again, defining rearrangements that have been described have been those that involve HMGA2 as well as plague. And so you can use immunohistochemistry targeting plague and HMGA2 to help you make a diagnosis of pleomorphic adenoma in a difficult case in a cellular or stromal-rich PA. Again, those antibodies are 70 and 10% sensitive, respectively, as well as almost 100% specific versus the main mimic, adenoid cystic carcinoma. For basal cell neoplasms, basal cell adenoma, as well as carcinoma, beta-catenin, nuclear beta-catenin expression has been described in about over 94% of these basal cell tumors, and it's thought to be 100% specific. So again, these beta-catenin mutations have been found in both, point mutations have been found in both adenomas as well as adenocarcinomas, basal cell adenomas or adenocarcinomas, so the IHC is helpful here as well. Another context you always hear about the use of IHC would be in the diagnosis of acinic cell carcinoma, especially vis-a-vis mammary analog secretory carcinoma. Again, these tumors overlap morphologically. They're both low-grade malignancies, so it's not super important to accurately distinguish them. But if you have a cell block, mammary analog secretory carcinoma tends to be positive for S100, mammoglobin, as well as GATA3, and acinic cell tends to be positive for SOX10 and DOG1. Importantly, none of these immunoprofiles are 100% specific, so you really have to have the right morphologic context and be suspecting one of these lesions for the IHC to really be confirmatory or useful. Again, there's lots of overlap between these lesions, so you really have to know the question that you're asking before you start doing the stains. because you can't just make a diagnosis based on the IHC alone. It has to be in the proper morphologic context. For the high-grade tumors, things that you can do, we alluded to. For carcinoma X plemorphic adenoma, the carcinoma's X plemorphic adenoma will retain immunoreactivity in many cases of HMG2 and plague. And for high-grade salivary gland ductal carcinoma, again, this is the analog of androgen receptor positive triple-negative breast cancer. So it tends to be positive for GATA3 as well as androgen receptor. And for high-grade mucoep, P63 might be something that would be useful as well, as would a simple mucin stain. I'll try to go through these reporting schemes very quickly. I realize I'm kind of out of time. So again, there's a couple of reporting schemes that have been described in the last year or so. One is the Milan system that I think people are familiar with. The other one is this system that's been proposed by the people at Pittsburgh. And so they took a very novel approach. What they did was look not at the individual diagnoses and individual neoplasms and entities, but what they did was that they looked at the various morphologic patterns that you see in these aspirates, and to each of these patterns, they assigned a risk of malignancy. So, for example, if you have a basaloid neoplasm, that on the whole has a risk of malignancy of 37%. And if you look at these aspirates and you characterize them based on what type of stroma you encounter, you can refine the risk of malignancy even further. So basaloid neoplasm with a fibrillary stroma is 15% risk of malignancy versus with hyaline stroma, for example, 43% risk of malignancy. So, they looked at the aspirates, the ones that you could definitively diagnose, the PAs and the Warthin tumors, they did as such, and for the rest of them, they just defined them based on morphologic pattern and assigned a risk of malignancy. So again, a novel approach, and I think the value here is that even if you don't employ this system, it kind of gives you good information about what features are kind of worrisome in each of these patterns. So in the basaloid pattern, you can, based on this work, recognize that tumors with hyaline stroma are more likely to be malignant than those with fibrillary or Northshore. And for the oncocytoid pattern, the ones with mucinous background tend to be more likely to be malignant than the ones with other cyst background or no cyst background. So a novel approach, very interesting. There's about 15 categories here, so how applicable and reproducible it would be in routine practice, I'm not quite sure. They further refined their classification down to, I think, 7 or 8 separate categories. Again, you take out the PAs and the Warthins, and the rest of the tumors you just basically define on the basis of the morphologic pattern as opposed to a specific diagnosis. So again, you can see that this actually works out pretty well as far as predicting malignancy goes, but again, too many categories still to be necessarily useful on a day-to-day basis, at least for my money. The Milan system is probably the one that everyone is the most familiar with. Again, this document was just published in the last year or so, and it was the product of a few years' worth of work from this international sort of group of collaborators. And so, the document defines the morphologic features for most of the common types of salivary gland neoplasia, and it also, takes a standard sort of reporting system for cytology and refines it a bit. So again, just like with any other organ system, we have non-diagnostic, non-neoplastic, benign. There's also atypical, suspicious, and malignant. But the one novel thing they did in this category is they took the neoplastic category and divided it up, just as the Pittsburgh people did actually, into tumors that you can definitively call benign, meaning PAs and Warthins, that they separated out, and then everything else that was a neoplasm but was uncertain whether or not it was malignant. So that would basically include oncocytic tumors that weren't Warthins, as well as basaloid tumors predominantly. And so when you divide up tumors like that, again, using our standard reporting system that we use in cytology, except splitting up the neoplastic category into uncertain malignant potential lesions, as well as the benign neoplasms category, again, which encompasses predominantly PAs and Warthins, you can see that the risks of malignancy for the non-diagnostic category is about 25%, non-neoplastic 10%, benign 3%, uncertain malignant potential 37%, suspicious about 60%, and in the malignant category about 92%. So interesting to see how the risks of malignancies sort of shook out in all those in all those diagnostic categories, and also interesting to see how they divided up the neoplasm category. So I'll kind of end there. I think in salivary gland cytology, the most important distinctions are between neoplastic and non-neoplastic on the one hand. And again, a diagnosis of malignancy isn't necessarily the most important thing. It's really the distinction between benign and low-grade malignancies on the one hand and high-grade malignancies on the other hand, because those are treated more aggressively. Pattern-based approach is useful, as with most other organ systems, although recognize that a lot of times in the basaloid and plemorphic categories, the basaloid category in particular, you really a lot of times will just have to be descriptive because there's quite a bit of overlap between benign, low-grade malignancies and high-grade malignancies within that basaloid pattern. So again, that's the area that gives us the most trouble, and a lot of times you just have to be descriptive. And in the right context, IHC can be used on cell blocks, especially if you're lucky enough to have access to some of those newer antibodies based on the translocation products that have been described as being kind of defining for various salivary gland tumors. All right, and I think I'll end there.
Great. Thank you so much. That was a great talk. I like your approach and some wonderful images, which are always appreciated. For the audience members, if you have any questions for the speakers, please don't use audio. If you've been muted, just keep it on mute. But if you could use the chat box or the question and answer box, just make sure if you're sending a chat question that it gets directed to all participants or me so that I actually see it. And I'll read the question to the speaker. Okay. So while I'm letting people figure out how to find that and ask questions, just was curious about how you generally approach the F&A on site as far as when you decide to, for instance, take maybe dedicated passes for a cell block or do any sort of triage when you're on site for these lesions.
Right, that's a good question. So I think most of the time, if you're dealing with something like a PA or a Warthin's, which again tends to be maybe 50% of the time, you can just get an aspirate and you're kind of done with it. Beyond that, I would say if we're dealing with a high-grade malignancy, a lot of time we'll request a cell block or a core, and we can use IHC. And I think we've actually had a fair amount of success because, again, you can usually find AR positivity in the ductal CAs. P63 can at least help you suggest a mucoep as long as you're not worried about a metastatic squamous cell carcinoma. So we've had some luck with the high-grade malignancies, playing around with those with IHC. A lot of times for the basaloid tumors, we'll request material for a cell block or get cores as well, but most of the time, even with the cell block or core, we still don't have a lot of trouble working it up. Sometimes you'll be lucky enough to find, some chondromyxoid stroma or squamous metaplasia on your cell block or core, and that will point you in the direction of a PA, for example. But again, even with IHC, most of the time with these basaloid sort of tumors, you're left just giving a differential. We're not lucky enough to have, IHC for MYB and HMGA2 at my current institution, but I think those might be things that would be useful if you had them. But I think in most places, even with a cell block, with these basaloid tumors, you're going to be end up left giving a differential a lot of times.
Still waiting for some questions. There's been many people thanking you, just so you're to take note of that through the chat box. Also, I think with the core biopsy, at least in my experience, it's usually, of course, in conjunction with radiology doing the procedure. There sometimes is a lot of hesitance, either due to, I've read in the literature, concern for possibly damaging the facial nerve, but I think usually more concern for, if it's a lesion that ultimately isn't surgically removed, a concern for fistulization. I don't know how common that is, but I'm just curious as far as, because we've discussed this at our institution, as far as if there's any standard situations in which you would want a core biopsy or not get a core biopsy, if that was an option at that particular procedure.
I think the time when it's probably the most useful would be if they're worried about a MET. If they're worried about a MET, again, it's usually going to be breast or lung, and they're going to want something like PD-L1 or hormone receptor on it. So I would say those ones you definitely want to get a cell block or a core. Again, most of the time, especially for Warthin's and a PA, you can make the diagnosis on an aspirate. And honestly, I would rather make the diagnosis on an aspirate in those specimen types. So even if they are going to be inclined to get a core or a cell block, I'd rather have an aspirate. Like, that's one thing I try to convey to the radiologist, because sometimes, especially if we're dealing with fellows that are trying to be gung-ho and aggressive, they'll jump straight to cores, and try to explain, like, really the way to diagnose these lesions is based on aspirate. That's where all the literature, that's where everyone's experience is dealing with aspirate. So I'd almost prefer an aspirate over a core for a lot of these salivary gland lesions. And yeah, I think, again, the times when I really want the core is, I think, if you're dealing with a metastatic lesion, and again, it's usually going to be something, or a lot of times, if it's not head and neck squam, going to be something like lung or breast, and those are ones that I'm really going to want to do IHC on, A, to prove it's a met, and B, because somebody's going to be, breathing down my neck to do things like hormone receptors and PD-L1 and whatnot.
Yeah, so it sounds like, having the confidence from experience helps a lot, and to be able to communicate with the radiologist and clinicians to really be strong with telling them what's important about the smear and cytopathology seems to be important. There is a question about when encountering a basaloid pattern with less than 25% of fibrillary material, how would you diagnose that situation?
I think I'd probably diagnose it kind of as such. I mean, I feel like if you've got just a little bit of fibrillary material, I might downplay it. If you've got quite a bit, but maybe not. I mean, 25 is arbitrary, obviously. It was just an arbitrary number. But if you've got enough, in my mind, again, if you're dealing with a salivary gland tumor and you have chondromyxoid stroma, which is basically what that fibrillary stuff is, chondromyxoid stroma, that's essentially pathognomonic for a PA. So if they're not worried about it clinically, and you've got a little bit of what's at least in your mind convincing fibrillary stroma, you could say if basaloid neoplasm, but then say you favor a plemorphic adenoma, and that's usually enough. Again, the key thing is that most of these things are going to be resected, so that's usually enough.
Okay. Well, thank you very much, and thanks for all the participants. You can keep up to date with our schedule of webinars on the IAC website. There's a link to the webinar website. For people who came in late or had trouble with the audio, this will be archived within a day or two on the same website. You'll be able to listen to the audio along with the PowerPoint through the player. Also want to give a shout out to the new Twitter account that's for the IAC and is been live tweeting the Twitter. You can follow it at the handle IA Cytology on Twitter. So that's been really helpful, and thank you very much for that. At that, I'm going to end the meeting, and thanks again for speaking. It was wonderful.
Thanks a lot for your time. I appreciate it.